It's an honor to introduce our article through this video clip. I'm Moon-Young Choi, one of the co-first authors of the article. Deep learning reconstruction has been successfully applied to multiple sequences of liver MRI. Deep learning reconstruction significantly reduces scan times and enhances image quality, offering the potential to optimize workflows without compromising diagnostic information. However, most research has focused on the performance of individual sequences, with the effects of combining multiple deep learning sequences remaining relatively unexplored. Abbreviated MRI was initially proposed for screening and surveillance of HCC in the liver, but its use has since expanded to include various liver diseases and other abdominal pathologies. Implementing deep learning accelerated sequences for AMRI could offer significant benefits. Despite the promising results of AMRI, few studies have assessed its application in liver AMRI. The purpose of our study was to construct an optimized deep learning accelerated non-enhanced AMRI protocol comprising DL accelerated SSFSE and DWI based on human and MRI phantom results. We further compared this protocol with standard AMRI in terms of image quality and malignant focal hepatic lesion detection across two centers. Our retrospective study was structured into two phases. In a preliminary study for imaging protocol optimization, we acquired the SSFSA-DL and DWI-DL sequences from humans and an MRI phantom to generate and test various AMRI-DL sets. In the main study, the optimized deep learning accelerated sequences and AMRI protocols were validated at two study sites in terms of image quality and malignant lesion detection. We used T2 and diffusion phantom. In the main study, 54 and 107 consecutive patients underwent liver MRI using the optimized AMRI-DL protocol at each site. Patients were excluded from the analysis if they could not cooperate with the breath-hold sequences, lacked DL sequences, or lacked a reference standard for the diagnosis of focal liver lesions. We used the standard liver MRI protocol with generally accepted sequences. For the AMRI protocol, we designed two main AMRI sets across the two sites. The standard AMRI consists of a combination of standard SSFSE and standard free-breathing DWI. The AMRI DL was composed of the same sequences but with deep learning reconstruction applied. At Site 2, since respiratory triggered DWI remained part of the routine MRI, we additionally analyzed two more AMRI sets. One combined standard SSFSE with respiratory triggered DWI, while the other, AMRI hybrid DL-SSFSE plus standard RT-DWI. This table shows the detailed MRI parameters. For qualitative image analysis, all AMRI image sets were independently reviewed by 3 board-certified abdominal radiologists, each with more than 10 years of experience in liver imaging. Sequence names were removed for the blinded review. Liver edge, vessel sharpness, motion, and non-motion artifacts, image noise, and overall image quality were rated on a 5-point Likert scale with higher scores indicating better quality. The conspicuity and margin sharpness of focal lesions were accessed using the same scoring system. The average scores of the 3 readers were used for further analysis. The same 3 reviewers evaluated the presence of malignant focal hepatic lesions across the 4 AMRI sets with a 2-week washout period to minimize recall bias. The datasets were reviewed in the following order. The MRI results were deemed positive for malignancy if a discrete lesion exhibited mild to moderate to hyperintensity or definite diffusion restriction, at least in part, on high p-value DWI images. For positive cases, the reviewers documented the size, segment-wise location, and sequential numbering of detected lesions. The statistical analysis was performed as follows. Let's see the results. The main study included 155 patients, including 160 patients with chronic liver disease. A total of 130 patients were identified as being at risk for malignancy, defined as those with chronic liver disease or current or previous intrahepatic or extrahepatic malignancy. The characteristics of the patients and focal lesions are summarized in this table. Of 119 focal lesions, 104 were malignant. ACCC was the most frequently diagnosed malignancy, followed by metastasis. This figure shows the qualitative analysis of single-shot FET spin echo images comparing the standard and deep learning methods. Compared to standard SSFSE, DLSSFE achieved significantly higher scores for all evaluated parameters. The agreement among the reviewers is summarized in this table. The inter-rater agreement for deep learning sequences tended to be higher than for their standard counterparts. The sensitivity for detecting malignant focal lesion in standard AMRI was 97.6%, and that of DL AMRI was 97.6% without significant difference. No significant difference was observed in sensitivity between sites and across reviewers. The sensitivity of AMRI for detecting HCC in a subgroup of patients with chronic liver disease showed no significant difference between standard and deep learning AMRI protocols. In this 61-year-old male patient with rectal cancer metastasis, 3 metastatic lesions of varying sizes are clearly visualized in both the standard and deep learning accelerated sequences. Reduced noise and artifacts are evident in deep learning T2 and diffusion-weighted imaging compared to the standard protocols. Our study demonstrated that pairing deep learning SSFSE with deep learning free-breathing DWI as a non-innocent AMRI protocol consistently delivered superior image quality while maintaining high sensitivity for malignant focal lesion detection across different sites and readers. Additionally, we achieved a 50% reduction in scan time compared to standard AMRI. For detecting HCC in patients with chronic liver disease, deep learning AMRI achieved a comparable sensitivity to standard AMRI protocol. These results highlight the potential benefits of deep learning acceleration in liver AMRI protocols. Our study has some limitations. First, its retrospective design may have introduced selection bias. Second, we only compared non-enhanced AMRI sequences without evaluating the added value of hepatobiliary phase. Third, the results may vary depending on reviewer experience, as only experienced reviewers participated in our study. Additionally, excluding lesions smaller than 4 mm may limit applicability in screening or surveillance setting. Recall bias is also a potential concern, especially at Site 2, despite a washout period. Finally, the exclusion of prior imaging deviates from clinical practice, which may affect generability. In conclusion, compared to standard AMRI, the deep learning AMRI protocol demonstrated significantly improved image quality and comparable sensitivity for detecting malignant focal liver lesions, including HCC, while reducing scan time by 50%. With its excellent sensitivity and efficiency, deep learning AMRI represents a promising option for screening protocols. Thank you.